right, this is the moderator, and Chair Sullivan, please feel free to begin.
Okay, thank you very much, and thank you to everyone for your patience. It has been over 2 years since we've gotten together, so what is the difference of another half hour? I'm not sure this room is big enough for us, but I think we'll see if it works out okay. I'll call the meeting to order, and let's go ahead and do the roll call.
Cozy up to you. Dr. Sullivan?
Here.
Ms. Sheffield? Here. Dr. Bradbury? Here. Dr. Lazarchuk is absent today. Ms. Laredo? Here. Dr. Payton is absent today. Ms. Ferber? Here. Dr. Sequoia? Dr. Sequoia, you might be muted.
I'm here.
Thank you. And Dr. Sequoia, can you confirm that you are calling in from the address listed on the agenda as 22320 Foothill Boulevard, Suite 220 in Hayward, California, 94541? Dr. Sequoia, I think you might be muted again.
Okay. Yes, I'm calling in from the DCA Division of Investigations Plaza Center in Hayward.
Perfect. Thank you so much. Ms. Usry? Here. And we have a quorum.
Thank you. Let's see here. So the first item on the agenda is comments and remarks from myself and committee members. My only comment is it's darn good to be back in person and doing some traveling. So members of the committee, any comments? Okay. Then we will get started with the first item then would be the public comments on items not on the agenda. So let's start with the moderator to see if there's any public comments from the public on the webcast first.
Thank you, Chair. And because this is a hybrid meeting, we will be doing things slightly differently. So when the chair calls for public comment, members of the public who would like to provide public comment at our DCA headquarters location in Sacramento can approach the table and microphone at the front of the room. For those participating at the Hayward location, you can let the committee or staff member know that you wish to make a comment by raising your hand. When called upon, we ask that the committee or staff person present provide the commenter access to your microphone. And for those of us joining us on Webex, we will be utilizing the Webex question and answer panel, also referred to as the Q&A, and you can raise your hand to facilitate public comment. When public comment is called for, I will open the Q&A panel, which I've already done, and you will, if you wish to make a comment, you can click on the Q&A icon, type the word comment in the text box, and send your comment to all panelists, or you may simply raise your hand. We are displaying instructions, and we'll give you a moment. So in this Sacramento location, do you have any requests for public comment?
I see none.
Okay, thank you. And in the Hayward location, do we have any requests for public comment?
No, we do not.
Thank you. And I do see that in Webex, we do have a request for comment. So we have a request for comment from Dan Femini. So Dan, you should be able to unmute yourself. Oh. So Dan Femini, did you want to make a comment?
Hello, my name is Dr. Dan Femini. I'm a practicing veterinarian, and for the last 10 years, I've also been the coordinator of the Santa Rosa Junior College Veterinary Technician Program. I really appreciate the opportunity to connect with the committee. And so I have a number of concerns, but two primary concerns regarding proposed changes to what has been traditionally called the alternate route for education, which is the set of regulations through which my community college program operates. Primarily, number one, as the new regulations are written, or at least the copy of them that was sent by the board, dated from 2020, it will require any student to have at least 2,000 hours of experience prior to beginning such a program. While I certainly understand the rationale to have certain hours of experience before they complete the program or before they get to a certain point, to have that big a burden before they start any classes, before they can start things such as biology or introduction to the career of veterinary medicines, is going to be a deterrent and will prevent many potential wonderful employees from entering our career. In the Sonoma County area, which includes approximately 100 premises, we are the primary education source, with over 85% new RVTs being graduates from our program. This would completely decimate the number of employees entering when it's really and critically needed. Second of all, as per that memorandum which I was sent from 2020, it stated that the new changes in terms of educational content would be put in place as of summer of 2024. If that timeline is still going to be adhered, that will also end this kind of program for a number of years. It takes over 2 years for any changes in curriculum from the time paperwork is submitted before it is implemented in the classroom. That's the length of getting through the bureaucracy of the California education system. And so that would mean any interested student who would start classes this fall would already be too late to adhere to changes. Furthermore, when we do have any changes to the curriculum, which overall I certainly do applaud and appreciate the overall changes to the educational content that are proposed, but the implementation of them, if there's not a grace period in which an overlap in which students from either set of educational requirements would be accepted, that will require some people to completely start over and likely leave this pathway and leave this workforce. And so I appreciate the opportunity to speak to the committee. I would love the chance to connect and be able to contribute any further insight from the community college perspective. And I thank you guys very much.
All right. Thank you, Dr. Femini. And I see no further requests for public comment. Mr. Chair, would you like me to close the Q&A panel?
Please do that.
All right, it's closed.
Okay, the next item on the agenda is review and approval of the January 18 committee meeting minutes. Does anybody have any changes or additions? If none, I need a motion.
Move to approve the minutes. And I'll second.
Okay, there's been a motion to approve the minutes and a second. Any comments from the board, from the committee? Then I would open up to the public. Any public comments? We'll start in the room. Are there any comments from the people here in Sacramento? Then I will turn it over to the moderator.
Thank you, Mr. Chair. Do we have any comments from Hayward? Any public comments?
We do not.
Thank you so much. And for the people logged into Webex, you may raise your hand, or you may use the Q&A panel located in the lower right-hand corner of your screen. Simply type comment and submit it to all panelists. We are displaying instructions and we'll give you a moment. All right, I see no requests for comment at this time. Shall I close the Q&A panel?
Yes, please.
Okay, it's closed.
Roll call, please, for the vote.
Dr. Sullivan?
Yes.
Ms. Chaffels?
Yes.
Dr. Bradbury?
Yes.
Ms. Laredo?
Yes.
Ms. Salazar-Sperber?
Yes.
Dr. Sequoia?
Yes. Yes.
Ms. Usry?
Yes.
Motion carries.
Thank you. The next item on the agenda is item number 5, which is the work on considering potential amendments to California code regarding animal health care tasks for RVTs. Leah and I were the subcommittee on this, and so I'll turn it over to Leah to give an overview, and we'll fill you in on what our recommendations are.
Good morning. Thank you, Dr. Sullivan. So,
A little closer to the mic.
thank you. So we have taken on the task of looking at expanding scope of practice according to discussions that CARVTA, California RVT Association, had asked us, and then the board gave to the MDC to look into expanding tasks for RVTs for that a pet owner would be able to do on their own, but having RVTs do them outside of the clinic. And that's kind of where this discussion started. And we were looking at this based off of access to care issues as well. So when we went through rules and all those things, we were looking at veterinary care access two ways. One, of course, is a physical distance that may limit pet owners getting veterinary care. The other is the cost of veterinary services that can change access for some families. So we did look at the thought that there's some RVT mid-level practitioner discussion going on that we've been made aware of. But at this time, we actually, as a subcommittee, believe that some of that discussion is premature because RVTs are not being used to our fullest potential at this time. We also are looking into the possibility of RVTs within a clinic setting to do tech appointments and with limited services being provided to animal patients, therefore lowering the cost of those services and still providing protection to the consumers. And we're working with some stakeholders on that as well. And then for the originally discussed request of CARVTA for RVTs to be able to independently administer treatments to animals outside of the vet premises, we reviewed the regulatory requirements, and a large part of this, or all of the Practice Act for RVTs, does bank on the supervision of RVTs by a veterinarian. So that's a key part of all of the tasks. So at this point, what we see is that we would not be able to just change this without needing statutory changes that would allow these tasks to be done outside of the clinic setting with no supervision by a veterinarian, then would have to go through statutory changes. So that's kind of where we're at as of right now with those, with our discussions.
Yes, and we also found in this discussion that since this is a scope of practice issue, that it is not something that the board can actually initiate. So any statutory changes would have to come from to the legislature from an outside organization or association. Going back just a little bit on the issue of the mid-level practitioner, you'll see a lot of that in articles in the veterinary journals and other information, other periodicals. And it's a buzzword out there. There's a big push for this. The only program that I've been able to find is one presently being offered at Lincoln Memorial University in Tennessee. It's called the Masters of Veterinary Clinical Care. It does require a bachelor's degree, and you have to be a licensed technician to apply. It is a 30-credit online program that you can complete in 1.5 years, and it's at a cost of $19,500. This information I did get from their website. It also includes a disclaimer, and I'm quoting, "At this time, the MVCC degree does not lead towards additional licensure qualifications. Students are required to be licensed in their field prior to entry and must maintain compliance with state laws after graduation." So I think it's very premature to be looking at this type of licensure at this point, or this type of degree, especially when we believe that we have a workforce out there now that is being underutilized, and any way that we can expand their ability, their tasks, I think would be a great benefit, especially in this time that we're discussing workforce issues. So with that, I will open it up for committee members to comment on as to what the discussion, what our subcommittee is bringing forward. Yes, Dr.
So first, I want to thank the subcommittee for that research. I know that at a board meeting, it's hard to tell when this happened because everything is kind of a blur, but Dr. Nunez had reported that there was some sort of an additional certification for RVTs with a bachelor's degree. I don't know if it's the same one you mentioned, so it's something that's been on our watch list. I absolutely agree RVTs are underutilized as far as their skills. And can you hear me now? So it's true that RVTs are being underutilized, and with this issue, I see both sides of it. I always tend to err on the side of caution. So right now, as an RVT, I'm almost autonomous in protection. If I do something wrong, my veterinarian is responsible that I work for. So there was a lot, I had mixed feelings about this to begin with, but I do agree it's a little bit premature. I don't think it's off the table, but I think it's something that we can continue to watch.
Yeah, I do know that the RVT program does have areas of specialization. Again, another area that's already there that I think is a good area to encourage RVTs to pursue. And with those skills, I'm sure they are at a better earning level. Yes, Dr. Bradbury.
So can you guys hear me okay with my mask on, or should I take it off? You're okay? Okay. So I understand this is a scope of practice issue, but I just am wondering if there is any other, anything else we can think of or advice we can give. In regards to protecting consumers, we have a large number of consumers that have dedicated themselves to their pets and have these pets with special needs that are going on vacation. Now the clients are going on vacation, and they need pet sitters that can provide, you know, medical treatments to their animals. And by telling you know, this is basically the reality of the regulations and the Practice Act the way it is right now. RVTs are not allowed to provide those services, and so it's I'm not sure how the pet sitters can proceed when clients need these services for their pets and consumers need these services for their pets. And so CARVTA can go through legislation, but is there any other? Is it if they're not advertising or acting as an RVT, or I'm just trying to figure out how consumers can have the best service, you know, and I know it's not necessarily in our purview, but that was the concern here in the
Yes, and they actually can get those services provided, but they can't charge for them. What CARVTA is asking is the ability for an RVT to provide those services for a fee. So, and I would also add, probably doing it through legislation will be quicker than doing it through regulation, the way the regulatory system is set up. Yes, Jennifer.
I just wanted to clarify, RVTs can perform those tasks and charge for them if they're working under the supervision of a veterinarian.
Correct. Yeah, the request is independently. You're correct. Yeah. Yes, Ms. Serber.
So with regard to scope of practice, I think the most efficient way to do this is through legislation, and I would look at it sooner rather than later. You know, in terms of the timeline, I think it's, you know, the fall is something that the board, you know, whoever is going to sponsor the legislation, that would be a good time frame. It does remind me of other scope of practice issues that I've worked on where they've allowed, say, nurse practitioners to practice outside the purview of a physician if certain hourly requirements or efficiencies, knowledge are proven by the nurse practitioner, for example. So it seems like there are a few things you can be creative about in, you know, making sure that the RVTs are sufficiently trained, that they can perform these duties, they provide a level of consumer protection that you know, we as consumers could rely on. I think there's some way to craft the language that would be beneficial to RVTs and to consumers.
And you're suggesting that through legislation, correct?
I would suggest that through legislation. I think the rulemaking process is longer.
Yeah.
And you can really take a look at other boards under DCA where they've done something very similar. And I think you can see some of the language in which was very successful, and probably by now see some of the things that maybe did not work in other areas.
Well, we did come up with some language that was pretty straightforward. It just got shot down in regulations. I'm not going to point any fingers, but I think she's up here at the table.
Not it.
Okay. Any other comments from the members of the committee? Otherwise, seeing none, I'll open it up to the public here. Oh, I'm sorry, Dr. Yes, Dr. Sakaya.
Yeah. I would like to thank everyone who elucidated what the conditions are that RVTs can practice outside of the clinic. I'm a little confused. And don't have the depth of knowledge that some of our other board members have. I know I've certainly had the pleasure of working with a number of our RVTs who have advanced specialized training and certifications. I did not realize that did not impact their licensing with the VMB. Is there any way that that would be a route?
I'm not sure I understand what.
Okay. For the RVTs who go on and get advanced training and certified, let's say in anesthesia, so they're like a nurse practitioner who's become certified as a nurse anesthesiologist. What to go to say to look at the analogous situation? Are those nurses under the DCA nursing board? Do they have a slightly different scope of practice attached to their license, like veterinary specialist licenses versus a general veterinarian, or is it just one flat license and it's what you choose legally to do within it? Does that make more sense?
Yes. As I would approach that, the license that a veterinarian has is the same whether they're a general practitioner or a board specialist. The difference comes in the standard of practice. If there's a disciplinary case, a specialist is going to be held to a higher standard than a general practitioner. I would assume the same is true if an RVT has a specialty in anesthesiology and, you know, again, would be held to a higher standard, but it's at this point still the same license. Jessica?
Right.
I think from looking at it over a couple of meetings, I think the only avenue that we could come up with is addressing the scope of practice as an exemption to the Practice Act, which would then limit them to certain functions. Sort of like what Ms. Sperber was mentioning. We can craft it to protect the consumer, but allow some more flexibility for the RVT. Okay. Tara?
I think what we were really kind of contemplating was perhaps CARPTA going to the legislature and potentially seeking an exemption, just like the shelters just got under BPC Section 4827, Subdivision A5C, which will authorize in certain circumstances the provision of medication under a veterinarian's guidelines at the shelter in conformity with the prescription issued by a separate veterinarian not employed by the shelter. Because that's really what we're talking about, is an RVT providing medication and some other veterinary services without any veterinarian supervision. So what does that look like? Our Practice Act hinges all RVT services on some level of veterinarian supervision, whether it's direct or indirect supervision. So the ask from CARPTA is providing a way for RVTs to perform these services with no veterinarian supervision, and that's going to take a legislative fix. We could not do that in regulation because currently the Practice Act requires some level of supervision. So to do that, we were thinking that the scope of practice could be effectively expanded if RVTs could be given an exemption from the practice of veterinary medicine, similar to what shelters just got last year. So that's kind of the idea, if we're talking about giving CARPTA some ideas to work with the legislature. It's just the board would not be able to sponsor something like that because the board does not recommend changes to scope of practice.
Yeah, one thing I wanted to add, and I have to apologize to committee for not bringing this up before, but I just thought about it. When we have the conversations about providing an exemption to the Practice Act for the RVTs, what you're also doing is removing any consumer protection mechanisms that the board provides. So, because you're exempting them from the whole act, so we wouldn't be able to hold them accountable to anything else in the act. Would never even need. It could require the RVT to do it, but if the RVT did anything while providing those services, they're exempt from the whole act. So if something goes wrong, the consumer would file the complaint. We would have no jurisdiction over any services they did if they were using that exemption.
Right, so it would be more that so carving them out of the act as an exemption would be problematic, but when you write the language, it would have to be an expansion of the scope of practice that reserves this board's oversight. You have to make it so the RVTs could work outside the scope of a veterinarian so long as they have blah, 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 blah listed, which would give this board its oversight to protect the consumers as well as provide a way for RVTs to provide care to their communities. Yeah. That's the way I'm sort of thinking about it in my head.
Okay, thank you. Jennifer?
I have a question, and maybe this is a Tara question. So I just want to point out that the whole motive behind this was because there are pet owners who are looking for resources. As it stands right now, the RVT can do these things, but we're under the direction of a veterinarian. If we do it for free, we can do it. But my question is, we have the same skills, we have the same license. Can we still be disciplined if we are doing something for free and something goes wrong? So we do have that protection. Okay, so that is that was my question. Thank you.
Dr. Sequoia? She's muted.
Dr. Sequoia, you're muted.
Sorry. Okay, I'm concerned about, listening to Tara, what happens if there's no veterinary supervision and the RVT feels it's appropriate to give the animal a prescription drug? Where are we then?
Where, when we were discussing this, the parameters would be that the RVT would be following the directions of the veterinarian, particularly the prescription, that they could not bring in their own medication, they could not deviate from the prescription that's written or the directions that's written by the veterinarian. So there would be some guidelines there that would protect the consumer.
Good, because I was not comfortable with the way I was understanding the exemption.
Okay, Tara?
The language we were thinking about would not authorize an RVT to diagnose or prescribe. It effectively probably would authorize the RVT to administer some level of veterinary services and medication. So yeah, it wouldn't allow an RVT to prescribe anything or determine that a different prescription was necessary effectively to, and arguably to protect the RVT as well as the consumer. The RVT would only want to follow the directions that come with the prescription that the veterinarian issued.
Okay, any other comments from the committee? Okay, then I'll open it up to the public members here in Sacramento. The button.
Is it on?
Yep.
Now? Okay. Bonnie Lutz. Okay, in addition to defending veterinarians, I've been recently called by all kinds of different companies to consult on different business practices, if you will. And one interesting one had to do with RVTs doing this home care. But the pushback that I was getting was, what if we just let the vet assistants do it? Because vet assistants are sometimes very experienced, but they're not licensed. So therefore, there really is nobody who can say that vet assistants can't do that. I was very disturbed by that, and I strongly suggested that they not consider that business model. But I wanted to bring that up because you're having this conversation, because after I had that discussion, I was called by 2 other different parties on the same issue, which is, since vet assistants are not licensed, and I'm not talking about VACSPs, but since vet assistants aren't licensed, they're just basically folks. So they can go out and work and do these home care things while people are on vacation and administer prescriptions and do whatever they want, because there's nobody who can do anything. So I just wanted to bring that up. I'm very concerned about that.
Thank you very much. Anyone else here? Okay, moderator, can you check with the public on the Webex?
Thank you. And first, I'd like to check with Hayward. Do we have any public comment in Hayward?
No, we do not.
Thank you so much. We do have a request for comment through Webex, and that is from Anita Levy Hudson. So Anita, you should be able to unmute yourself now. So Anita, you should see a button to unmute yourself. Okay, she says it's not allowing her to unmute. Let me try that one more time. And so Anita, one option would be for you to type your question in the Q&A and I can read it, or your comment rather, and then I could read it. In the meantime, I'll go ahead and go to the next request for comment, which is from Nancy Ehrlich. So Nancy, you should be able to unmute yourself. There you go, you're unmuted.
I unmuted, did that work?
Yes.
Yes.
Okay. I just wanted to clarify that what we were proposing was allowing an RVT to do what the client is supposed to be doing. Did nothing beyond the prescribed treatment from the veterinarian. So that, I mean, it's kind of silly that we're having to go through all of this to do this, because clients are already doing these procedures, and obviously RVTs are way more qualified than clients to administer these treatments. And as was so rightly pointed out by Ms. Lutz, that a veterinary assistant is not restricted from performing job tasks because they're not really mentioned in the Practice Act having to work under supervision. So only RVTs are forbidden from doing this. And I think we're not going to have any problem going to the legislature and getting this changed because it's just not logical and it's not good for anybody. So I look forward to, I'm hoping that we can work with CVMA on this to get this done as soon as possible. That was it for me.
Thank you.
Thank you. All right, and let me try Anita one more time before we close. Anita, can you unmute yourself? Or you, Anita, you can also type your comment in the Q&A. Okay, she says she still can't unmute. So Anita, please feel free to type your comment in the Q&A panel. All right, so Anita types that my point is similar to Nancy's. I also wanted to say that it says that they're measures for accountability. And that is the end of requests for public comment. Would you like me to close the Q&A panel?
Yes, please.
Okay, it's closed.
So at this time, I do not see any action coming from the committee unless somebody has another idea. Okay, then we'll move on to agenda item 7. No, 6. So this is the possible actions regarding RVT education program, and I will turn that over to Jennifer and Leah.
Hello. So Jennifer and I were put on the subcommittee for RVT education programs, and overall what we were doing was looking at the statutes and regulations for board approval of RVT programs and trying to figure out if any additional consumer protection happens due to the board process for looking at programs. And so what I believe we found as we started to dive into this is a much bigger issue than we maybe realized in the beginning. I think the more we look at things, kind of the more questions that pop up, but we certainly have started into looking at this issue and looking at the different accrediting bodies for RVT programs. And as you all probably remember, we did have presentations by the AVMA Committee on Vet Tech Education, or the CVTEA, and the BPPE that looks at programs of private education for RVTs in California. Also, we do have programs that are looked at by the Accrediting Commission for community and junior colleges as well. So there are 3 other organizations or bodies that look at RVT programs in the state, as well as the programs having to be approved by the board. So we've taken some steps at looking further into what each of these groups do. Certainly the AVMA, CVTEA has their 11 standards for accreditation that are very in-depth for their programs, and They also, in that program, do have a pass rate that must be met by students for the VTNE in order to maintain accreditation, and that is something that the other organizations don't do at this time. And we did find there's 23 AVMA accredited schools in California right now. So we've looked at that. We're also trying to reach out to the other state boards to determine other states' requirements for education because we do have this kind of alternate route program in California as well. And then as another part of it, we are trying to see that if we did remove board approval for RVT programs, how that would affect out-of-state applicants and those things as well. So I believe it's typed in the memo here somewhere, but out-of-state applicants right now that are from an AVMA approved school do automatically get California approval for taking the exam, so that part wouldn't change. And then we still are needing to look over the RVT education rulemaking to see how that lines up with all of these things for now. So we believe it's early in our investigative actions here as a subcommittee, but so far the only thing we think we will be ready to move forward with potentially by next meeting would be talking about getting rid of the requirement for AVMA accredited RVT programs to also be approved by the board. I think we saw it last time as well. These other groups have thousands of dollars in application fees for their program, and we as a board, I believe, can charge $300. So, you know, a lot of potentially duplicitous work comes into this on our board level, especially for those that have already gone through the very thorough accreditation program from the AVMA. And I would mention that even if we change this, it would not stop the board from being able to follow up on a complaint on one of those schools as well. So we would still have our purview to go in and look at programs or follow up on complaints as the VMB, but we would not have to do a whole separate application process for those schools. So.
Jennifer, any addition?
Very well stated, Leah. No, I think Leah is absolutely correct in everything she said. We just need to do some more research because just like the last agenda item, when you start to research one issue, you run into something else. Changing one thing has that butterfly effect. So we need to do our due diligence and research all of the potential changes that could be made.
Okay, thank you. Dr. Bradbury.
I was just thinking about how at the end of this agenda item, you guys mentioned reviewing the board's RVT education rulemaking to see if additional amendments should be made. And after Dan, who spoke earlier, I just wondered if we want to kind of incorporate some of his concerns into looking at that rulemaking package as well, or what your guys' thoughts are on that.
Yes, I did take notes on those comments. It wasn't agendized, so we weren't allowed to discuss it, but I did take notes, and the subcommittee can discuss those concerns.
Okay, thank you. Any other questions? Okay, Dr. Sequoia, are you fine? I don't see her. Okay, then we'll open up for a public comment. People in the room here in Sacramento.
Dr. Sullivan, just while we're waiting on that, is there a way to put Dr. Sequoia on the screen instead of the moderator's initials so we can see her? Oh, okay, there's no...
I believe I'm on the screen, or I see myself.
There we go.
Okay, well, but the moderator's not talking and
differently.
she's on the screen, so is there a way to change their...
So Diane, I'll just ask you that if you have a question, just speak up, go off
Sure.
mute and speak up, and then
Yeah.
we'll be sure to catch you. All right, thanks. Okay, moderator, can you ask for public opinion, public comment on the Webex?
Thank you, Mr. Chair. I've opened up the Q&A panel, and if any public attendees signed into Webex would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. And I do see that Dr. Femini would like to make a comment. So Dr. Femini, you should be able to unmute yourself. There you go.
All right, hello, thank you once again. Very briefly, I primarily just wanted to get one point of clarification, which is based on what I just heard, is it safe to assume that the changes to the content that had been proposed are not on board to be put in place within a couple of years, that timeline is going to be delayed? So if I get clarification on that. And then second of all, I did articulate all of my concerns in a letter I sent to the Veterinary Medical Board as a whole. I'm very happy to send it to the committee. I just need to know how. And then also just want to make myself available if you guys wanted to check in with someone who's in the community college aspect of things, or if you wanted me to help connect you with the AJCC or any other the accrediting groups from within the community college system, happy to try to facilitate that connection.
How do we follow up on that?
All right, this is
Right. Okay, and is there any public comments from Hayward?
No public comments from Hayward. Thank you.
Thank you.
right,
Okay, we will take the information, the comments from the public, and make sure the subcommittee follows up.
And this is the moderator. Shall I close the Q&A panel?
Please do that.
Okay, it's closed.
Okay, moving on to action item 7 is a discussion on cannabis, and I will turn that over to Dr. Bradbury.
Okay, I was expecting you to handle that, but I'm happy to talk about it. No problem.
Do you want me to?
Yeah, do you mind? I know that this is
not at all.
kind of your baby here, yeah.
Okay, so this is in response to Dr. Pollard's request to address this, and what we discussed, we looked at a number of things. Let me get some notes here. So the memorandum is pretty straightforward. We felt that Dr. Pollard's request needed a response, and it was obvious to us that hemp CBD is an over-the-counter product and should be enforced as any other over-the-counter product. We felt that guidelines were not necessary for that. And since AB 1885 is going through the legislative process, which will, if passed, will require some additional guidelines to our I would say either additional guidelines or amendments to the guidelines we already have. So it is premature in addressing that. The conversation out there is that it looks like 1885 is going to move through pretty easily, and I have a little bit different opinion on that, in that this is an amendment to a proposition, and that requires a 2/3 vote in the legislature. So I know that when we worked on getting the discussion in, it was a lot of work to get the 2/3 vote. So we'll be following that pretty closely. The other comment I had regards AB 45 that was signed into law at the end of last year, and which allowed hemp CBD to be legally added to animal products, and that those products will be tested by a third-party independent state accredited laboratory for specific criteria, including THC content, but also free of any toxins, pesticides, heavy metals, et cetera. This is the first oversight that I have seen, and good oversight that I have seen, with hemp CBD. And following this in other states, I don't know of any other state that has that criteria, and I think it's a really positive step for consumer protection, because up until now, hemp CBD has been kind of the Wild West. What we are recommending is no action or no recommendation to the board at this time, but there may be other opinions out there. So I'll open it up to the committee right now for any comments. Okay. I didn't read all my notes, so there will be a recommendation to ask for a motion to not recommend any changes or any motion to the board. I'm sorry, let me get it correct. If the subcommittee agrees, please entertain a motion to recommend the board not update its guidelines at this time to include guidelines on hemp CBD products. Now I'll open it up again to the committee. Well, to Tara.
I just want to be, just to clarify the motion, that it would be a motion to recommend the board not update its cannabis guidelines. Otherwise, sometimes when we're doing the meeting minutes, it's just a little vague, and it's difficult for us to insert words after a motion has already been voted on. So I just want to clarify that it's the cannabis guidelines. Thank you.
Thank you.
I'll make the motion.
Well, let's have discussion first. If there's no committee comments, then I'll open it up for discussion for the public here in Sacramento.
I want a motion first and then public comment.
I'm sorry. We'll go with the motion first then.
Okay, I'd like to make a motion to recommend that the board not update its cannabis guidelines at this time to include guidelines for hemp CBD products.
I second.
Okay. Any further comments from the committee? I'm really still a rookie here. Give me a break. Okay, comments from the public here in Sacramento. Seeing none, we'll then open it up to the moderator for comments from the public and from Hayward.
Thank you, Mr. Chair. And do we have any comments from Hayward?
No, we do not.
Thank you. So I've opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists. Or you may simply raise your hand. We will give you a moment to access those features.
She did put the word cannabis in her motion. Okay.
All right, this is the moderator. I see no request for public comment at this time. Shall I close the Q&A panel?
Please.
Okay, it's closed.
Okay, with a motion and a second, we'll call the roll.
Dr. Sullivan?
Yes.
Ms. Phelps?
Yes.
Dr. Bradbury?
Yes.
Ms. Laredo?
Yes.
Ms. Allen-Farris-Berber?
Yes.
Dr. Sequoia?
Yes,
Ms. Essery?
Yes.
Motion carries.
Thank you. Boy, we are moving right along. Let's go to item number 8. Okay, so this is a discussion on the small animal vaccination clinics, and as it relates to the VCPR, we've had a number of questions, and then once we started getting involved in this, other issues came up. So Dr. Payton isn't here today, so I'll go ahead and start. The original intent of 2030.3 was to provide the minimum standards for a vaccination clinic to provide vaccines and over-the-counter preventive parasite control. It was also the intent of 2030.3 that if a vaccination location was doing more things such as blood tests and prescription medications and things like that, they would need to establish a VCPR so that there would be proper medical records that the client could have access to if it was necessary. The first obstacle that we encountered was looking at the definition of rabies, because it is classified as a dangerous drug, because on the label it says, and I quote, "restricted to use by or under the direction of a veterinarian." And as you can read from the memorandum, we have been doing a lot of low-cost rabies vaccination clinics throughout the state for the past 50 years with great public health success and great success for our patients. So our task was to exempt rabies vaccinations from the VCPR by adding sections B, Q, and R to 2030.3, as you can see on page 4, and also answering the question in the FAQs, question number 6, more directly. With an introduction provided by Dr. Grant Miller, I did have a conversation with Dr. Fritz and Dr. I'm not pronouncing that right, Camp-Agna, who are the rabies section, at the rabies section in the California Public Health Department, and they agreed that the language was acceptable to them. They also told me that it is law that every city and county have a rabies control program that includes at-cost public rabies vaccinations, rabies clinics. So I think we're going in the right direction. You know, there's quite a bit of material here to address. So I think we'll kind of take it one thing at a time. Probably the first thing to look at would be, well, first of all, I guess any comments by the committee on the background material that has led us to this? Jennifer.
I have a question rather than a comment. In subsection B, the proposed diagnostic test shall not be performed. I'm thinking of shelter medicine, and I'm thinking of maybe a cat coming in for an FELV, FIV vaccination. It's recommended that you test for that ahead of time. And I do see that in Q, that if that occurs, then they would need a valid VCPR. But again, in shelter medicine, we do have that new regulation that was mentioned. So would this exempt the shelter? Because if they do have that standing written protocol from their veterinarian, would they still be able to perform that? And I'm just thinking in the interest of public health and with wanting to get as many animals vaccinated as possible.
My understanding is that we are addressing issues outside the shelter with this language. Okay. So then I think what I thought we would do, and I'm not in any particular order, but I guess to me the most critical is the language for the VCPR, and I've got to get it here. That is in this section, right? Oh, I've got the wrong one here. It's on the next page. Yeah, but I was doing the VCPR first. So that is, that will be on page 4 of the memorandum. And it's under 2032.1, the VCPR, and we would be at the end of A, we would be adding, or rabies vaccinations are given in the interest to protect the public health. This is an exception to the VCPR. straightforward. Any comments by the committee? Do you want to open up to the public or do it at the end? Okay. All right. So what we'll do is go through all of the recommended changes and then open it up to and get a motion and then open it up to the public. So that's the VCPR language. The other issue is the addition of section B, Q, and R to try to clarify what our original intent was. So, in essence, if you're doing any diagnostic testing or prescribing any dangerous drugs, which means prescriptions, you have to have a physical exam and VCPR and complete medical records on that case. Dr. Bradbury.
I'm sorry, I don't have the entire thing in front of me, the other sections, but there's already an exemption for the antiparasitics, that's correct?
Okay, that's, if it's a dangerous drug, if it's a prescription, let's say a prescription flea medication, then a VCPR has to be done. If it's an over-the-counter product, then it does not.
Okay, I thought they were allowed to give dewormers.
If it's over-the-counter.
Okay.
So the question is that clear enough here? Okay. Okay. And then the third item is, well, first of all, I do have a question. At one point, under section F, it said if a rabies vaccination is administered, then only a visual examination of a patient shall be required to ensure that the patient is bright, alert, and ambulatory. At one point, there was a question as to the word bright, if we needed to remove that. Has that changed?
So that question came from our reg attorney, Karen Halbo, and what bright meant. The concern was it was vague and you needed to describe it more, and my thoughts were, is it even necessary? Is it necessary to it, or is alert and ambulatory enough?
Well, my opinion was that it's enough. We don't need the word bright, and I thought we had removed it, but it's here, so. Okay, that's right. So I will remove it in my, with our, when we come with our motion, we'll remove bright. And if the patient is not bright and ambulatory, in other words, if a client brings an animal in and it's a little dog and they're hugging him and won't let him out down to walk to see how it is, then the veterinarian still has the ability to physically look at the animal and check him over to make sure it's healthy enough for a vaccination, but does not have to do, does not require a VCPR established. Okay. Are you okay, Dr. Sequoia, with this?
Well, I like responsive in there simply because, and you've given me the opening, if the person is clutching the little dog or the little cat or the little whatever to their bosom, and they won't put it down to let it ambulate, at least if it's responsive, it's a good marker that it's healthy enough to vaccinate. So I think if you have local, ambulation in there, you should have responsive.
Well, the trigger here is if the people administering the vaccinations do not see that it's bright and ambulatory, there's always a veterinarian on the premises, then it triggers the veterinarian doing an examination to be sure that the animal's healthy enough for a vaccine.
Okay, I guess it's just semantics.
Yeah. Yes. Okay. And I mean, the public clinics that I have participated in, you're looking at, 200 or 300 dogs in an evening that takes 2 or 3 hours, and there's just no way you can do a complete VCPR and accomplish what is needed for the public good. So we're trying to define that entity in that setting without it being expanded. Okay.
I agree, Dr. Sullivan. I've done public clinics too. But I just think, you know, the animal can be alert and still not be responsive. I don't know, and you're missing it all on cats. There's no way the cat should be ambulating at the clinic. But I defer to everybody else.
Okay. Yes, Dr. Bradbury.
I think that's a good point. If we, instead of we commonly as veterinarians use bright, alert, responsive, and I think what she's saying is maybe instead of bright, have it alert, responsive, and or ambulatory. The ambulatory, because I see what you're saying, Dr. Sequoia, and I don't have a problem with having responsive in there. And some animals you don't want to put down, like cats. So I guess that is a concern, having that as a requirement.
So what is the wording that you would prefer? The patient is
maybe alert, responsive. I don't know if ambulatory needs to be in there, but I like that for dogs, but for cats, I see the point of not wanting them out and about. So I'm open for suggestions. I like the discussion on it.
Okay, and this is again triggers the oversight of a veterinarian. So
right, but if we require a veterinarian to come in every time a cat gets brought in because they're not ambulatory, they're just kind of cowering in the back of a cage, I don't know that that's serving the purpose. Like, that's not our goal. So I see I just see what Dr. Sequoia was saying. And
okay, so what wording then would be okay is that the patient is alert and responsive. Okay, that's what we're here for, the wordsmithing. Is that okay, Diane? Dr. Sequoia?
Sounds good to me. Thank you.
Okay, Tara?
I'm a little concerned about responsive. I just need to make sure that, similar with the concern about bright, what does responsive mean? Should we add, alert and responsive to stimulus? I just need to make sure that this is clear. And if anyone in the public, perhaps Ms. Lutz, has any concerns about what responsive means and making sure that that's clear.
Within the profession, it's clear, but I'm not sure it's clear in the public.
So, and I don't know if Karen Halbo is on the line, but she had said when she rose the concern with bright that we would need to put into the ISR just that if it was standard in the industry, that's why we're using it. So I think with this justification, this clarification that alert and responsive are common words in the industry, then I think as long as it's in the ISR, we may be fine. But I don't know if Karen is on the line, if she wants to weigh in.
I'm on the line and I've had my hand raised. I was thinking alert and responsive to stimulus gives me something more clear for the ISR. And you could say if the patient is a canine, comma, and if the patient is a canine, comma, ambulatory. You could keep that in there for dogs. You don't have to throw out that if you find it valuable as veterinarians. And I think paying attention to the cats gives you this. So you would say the patient is alert and responsive to stimulus, and if a canine, comma, ambulatory.
Jennifer?
I just want to point out that we would also have dogs that were not ambulatory. We've all had those fearful dogs crouched in the corner that we have to carry to another area. So I think ambulatory, I still don't like it.
Okay.
Got it.
So the new wording would be, the patient shall
Alert.
be I'm sorry?
Sorry, sir.
Shall
I
be
was gonna say-
required to ensure that the patient is alert and responsive to stimuli, period. How does that sound? Sarah?
Okay, to be clear, we're on page 4 of the meeting materials, section 2030.3, new subdivision R. This change would be made on line 3, so we would be striking bright in line 2, and in line 3, alert and responsive to stimuli, striking ambulatory, and making the same changes in the next sentence. If the patient is not, strike bright, alert, strike ambulatory, so it would read, if the patient is not alert and responsive to stimuli.
Correct. Okay.
Question?
Yes.
So as I understood Tara's remark, the animal would have to be both alert and responsive. If it fails on either one, the veterinarian is called in. Is that correct, Tara? Is that what you wanted?
Right. I initially raised the concern about what responsive means. Jessica did a great job of clarifying what the board's regulatory counsel would need to justify responsive to the Office of Administrative Law. And then Karen Halbo, the board's regulatory counsel, suggested alert and responsive to stimuli. So I think we're all on the same page now.
So the animal must qualify on both of those to get the vaccination, or the veterinarian has to certify an exception, correct?
Yes.
Okay, great, thank you.
Dr. Bradbury.
I hate to do this, but the word bright is very commonly used in our, that is, we start most of our objective data, our physical exams with bright, alert, responsive, quiet, alert, responsive, and an animal that is bright, alert, responsive is one that would typically be used, would be an acceptable candidate to receive a vaccine. And I know we just talked about taking out bright, but if there is a way to keep that in, I think it would actually be the most appropriate for the profession and for people to understand what they're looking for in an animal. So I know Ms. Halbo may need a better description of that, but anyway, that was just a thought I had while we're discussing this.
Dr.
Karen,
Bradbury? I'm sorry, go ahead.
So Karen, when you had originally raised the concern, you had spoke to putting it into the ISR that it was standard in the practice to use these terms. So it's my understanding that it's okay if we continue to use bright as long as we describe it in the ISR why it's industry standard.
Well, if I could be pointed to any sort of writing or materials where I can show that it's in the standard. When I kind of Googled for veterinary use of term, I didn't get anything, and so I was trying to let you know this is going to be a problem. And we can rely on the expertise of the board and the board's investigators to say it's a standard term. We've had very conservative reviews out of OAL. And I raised the issue because I wanted to know if someone could shoot me some sort of document that I would be able to use to cite to show it's a standard term.
The only reference I would have is multiple medical records that has in it as part of the examination, bright, alert, and responsive. I mean, it's a common phrase, but I'm not sure I could find it in literature.
And it's usually stated as BAR or BAR, so maybe that's why she can't find it.
If I may say something, perhaps the confusion is we are, as veterinarians, leaving out the word that should be coming after bright or quiet. It's a bright attitude, quiet attitude, in that it describes the mood, if you will, of the animal. So perhaps saying bright and putting attitude in parens would help. Just a suggestion.
So I just have a quick question with language, and forgive me, I don't know if this is correct or not, but when we're using, it sounds like bright and alert are terms of art so far as veterinary medicine go. So I'm wondering if there's a way you can put kind of what Dr. Sullivan was saying, like in the professional judgment of the practitioner, the animal is bright and alert. Just so we clarify that it's really left up to the practitioner who's determining, you know, and that gives them the flexibility. If the dog is cowering because it's terrified, it's just terrified. It doesn't mean that it shouldn't be given the vaccination. I just think giving the discretion to the practitioner based on their professional skill set makes sense. And I don't know, I mean, again, I don't know if I'm opening a can of worms, but.
So I think based on the fact that it is a common term, and I'm going to give a shout out to our moderator who Googled BAR veterinary definition, and it comes out to bright, alert, and responsive. So I think we can find the justification that our reg unit is looking toward to keep that language.
Sure.
I just wanted to make a note that we're not necessarily relying on individuals who have a particular education or experience administering these vaccinations, because really what we're talking about is animal vaccination locations where potentially you've got veterinary assistants, unlicensed individuals helping out, getting these animals vaccinated. So they're the first tier of examination of the patient. So they wouldn't necessarily know. I mean, hopefully the veterinarian they're being supervised by is training them for these cues. But I would just caution, you know, at least make the point that the first level is not necessarily a veterinary professional per se. It's not a veterinarian, and it may not be an RVT either. It's the second level where we get to veterinarians reviewing the animal. I just wanted to make that point. It's not necessarily professional expertise necessarily. So we do want to be a bit clear on what these potentially unlicensed individuals are looking for with the animals, so they can comply with this proposed regulation and get, you know, the animals vaccinated appropriately.
But that is the responsibility of the signature on the rabies vaccine. That veterinarian is responsible, just as in a shelter, to train and educate that level, that they are competent and know what the parameters are. Now, I don't know about what general vaccine clinics do. I just know what the community clinics that I worked at, where you took your own staff. So they were, you know, veterinary assistants or RVTs that were working for you and were at work every day and pretty much knew what bright, alert, and active is. But I don't know on other settings whether that's true or not. But I still think we have, you know, consumer protection in the license of the veterinarian that is signing the rabies certificates. Jennifer?
I just had a comment. In RVT programs, usually they have a veterinary office procedures course that covers terminology, and BAR and QAR are included in that terminology.
Good. Okay.
So do we want to keep it right?
I think so. So the motion, who made the motion? Dr. No motion yet? Okay. Did you have something?
I was just wondering, Dr. Pawlowski, I know we don't have a motion yet, but I know that he also has had a lot of experience with rabies clinics and rabies day and stuff, and so I just wondered if we could let the public comment before a motion in this case.
Okay. Let's finish what we were discussing first, and then we'll go back to it. The last item is that needs to be amended in any motion is the verbiage on question 6, I believe it is, in the Q&As. And let's see, that is where is that wording? Okay. Page 3. So we're, okay, so that's the entire question. The issue of the small animal vaccine clinics, I still had concern with how we're answering that, but I'll open it up to the committee members first. According to the way we have it worded, until we get the exemption on the VCPR for the rabies vaccination, it's still requiring a VCPR. And I don't know how we get around that, because this would be shutting down all of the low-cost vaccine clinics that are mandated by public health law.
Well, to clarify, you answering the question doesn't shut down anything. It's just stating what the current law does. So this is accurate according to current law. And until that VCPR exemption is put in, the answer itself is correct. Okay. Whether or not you want to highlight that, that's up to you.
I'd like to say something, Dr. Sullivan.
Go ahead.
I know that a number of counties and cities have said that they are not going to run low-cost public rabies vaccine clinics, and haven't for a number of years, sometimes even over a decade, because they feel the low-cost private vaccine clinics are meeting the need.
I'm sorry, what's the last part? The low-cost private vaccine clinics are?
They're not running public ones because they feel that the private vaccine clinic services are cheap enough that people are using that. I haven't heard of anyone giving vouchers for the private vaccine clinics. I'm talking about like VIP and some of the other vaccine services. Undoubtedly, Jessica would know more about what is going on with the current private vaccine services than I do.
Well, that's state law, so I think that the private entity here is satisfying the requirement of the city and the county. So, and this, is addressing that. So, I think we're okay. Besides, it's a issue with the public health department, not an issue with us. But I guess I would, personally, I'd like to see the last sentence removed. Tara?
The issue is just that the board and board staff get many questions about these issues and whether or not rabies vaccines can be administered without a VCPR, without a veterinarian. So, these are just frequently asked questions. Okay. You can either provide an answer to frequently asked questions or not provide an answer. But this, Jessica's right, it just states the law right now. That's what it is. We're not necessarily saying we're going to start going after vaccine clinics, making sure those dangerous drugs, those rabies vaccines are being complied with and a VCPR is established, because really you're already acknowledging that there's an issue by amending the regulation.
Okay.
We're trying to move forward with that. Whether or not you provide an answer to a frequently asked question isn't the real issue.
Right.
We are restating the law, exactly.
Okay, Dr. Bradbury?
Maybe the last sentence can be updated to say, however, at this time, administration of a vaccine that is a dangerous drug, et cetera, instead of it.
Yeah, I think that.
Just leave it. I'm fine with leaving it.
I think that emphasizes it more.
What if you add a sentence in the end that says that the MDC and the board are looking at proposing regulatory changes to that section?
Okay.
How long is it going to take?
Yeah. Yeah.
So,
Okay, so what's our legal counsel's recommendation, leaving it as it is?
yeah, my recommendation would be to leave it as is. Otherwise, if you start talking about proposed regulations that the board is looking at or contemplating or has adopted, we honestly don't know when those regulations might go into effect. After additional consideration, maybe the regulation proposal changes over time. We're going to have to, come back and keep an eye on these FAQs to make sure that they're properly updated as, regulatory language changes. The point of the VCPR FAQs is to give quick answers about the law.
Okay. All right. Then before a motion is made, we'll open it up for public discussion, and we will start here in Sacramento. Dr. Pawlowski.
So Dr. Pawlowski with CVMA. I don't know exactly what you settled on as far as the whole BAR comment there, but last I had heard you were contemplating saying responsive to stimuli. So 2 points. One, the definition of responsive when you look in a medical dictionary is the ability to respond to a stimulus. So it's redundant to say responsive to a stimuli, to stimuli. Also, if you put in to stimuli, you're implying that there are multiple tests to require different types of stimulation, because that's multiple. So are you requiring them to flash a light in their eye to see if their pupils respond, as well as to clap to see if they can hear? I mean, what is responsive? So I would argue responsive is good enough. It is well documented. Veterinarians know what BAR means.
Thank you.
All right, this is the moderator. Do you have any more?
We have another person here, so.
Okay, wonderful. Thank you.
Bonnie?
Hi, Bonnie Lutz again. I just want to also emphasize that BAR, I read a lot of medical records, and I'm not a veterinarian, but it's a widely used term. And I do believe that the vet assistants, or whatever level they are that are assisting at the vaccine clinics, completely understand what BAR is. I think that because this is written to be interpreted by veterinarians, we keep talking about protection of the public, but I don't have a lot of public people calling me to ask me how to interpret these regulations. I have a lot of veterinarians calling me to ask me how to interpret them. So BAR will stand out and make sense to them. I just don't want to bring up some other problems, but I'm just a little concerned about evaluated and healthy enough. Now, I know that a veterinarian will be signing off on it, so I'm comfortable with that. It's just evaluated by the veterinarian to be healthy enough. Healthy enough is such a broad term. And, you know, what if there's an animal who has some kind of health condition, but basically is, how do you determine whether it's healthy enough to get a rabies vaccine to prevent it from getting rabies? So I'm a little concerned about the vagueness of those, but I don't want to start a big discussion over that because I think that I'm comfortable being able to tell a veterinarian how to determine that and how they can look at it from their professional background and sign off on the record. But if anybody else was concerned about those terms. But as far as BAR, I really think that that's what you should use. Thank you.
Okay. I guess I would respond in saying that when a patient comes to us for only a rabies vaccination that's done by a veterinarian, I don't think that most veterinarians are going to run a bunch of tests to make sure there's not an immune disease going on or something like that. So unless there's some other need for defining the examination of the veterinarian, I think we'll leave that as is, unless, do you have some other wording? No, I was just suggesting that it is a little vague. I know I'll get a lot of questions about it. Okay. I'm comfortable to explain to a veterinarian how to make that determination. All right, good comments. So moderator, we'll turn it over to you for comments from the public on the Webex.
Thank you. And yes, and so do we have any requests for public comment from Hayward?
No, we do not.
Thank you. And I have the Q&A panel available, so if any member of the public wishes to make a comment, you may type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We'll give you a moment.
Okay.
All right, I'm seeing no requests for comment at this time. Shall I close the Q&A panel?
Yes, please.
Okay, it's closed.
Okay, any other comments from the committee? And if not, we have two action requests that would like to come from the committee.
Can we have like a reading of the new language?
Well, let's see, we want to do this one first. So this,
We didn't make changes to that.
no. So if the MDC agrees with the subcommittee to add the draft vaccination questions and answers to the board's frequently asked questions, please entertain a motion to recommend the board approve the additions and update to the document on the website.
I think I just meant so that, because we went back and forth about the wording of section R.
Yes, so that, okay. So section R would read, notwithstanding subsection G, if a rabies vaccination is administered, then, Q, if a rabies vaccination is administered, then only a visual examination of the patient shall be required to ensure that the patient is bright, alert, and ambulatory. And responsive, that's right. If the patient is not bright, alert, and responsive, then the patient must be evaluated by the veterinarian to be healthy enough to receive the rabies vaccination.
Okay, I'd like to make a motion.
So move.
Or so move, sorry.
I second that.
Okay.
Wait. Sorry, to clarify, there's two requested motions, so are you doing the VCPR language or the second requested motion?
The second.
Do you want me to redo the motion?
I can read it, sorry. Let's see. see here. I want to entertain a motion to recommend the board approve and adopt the additions and proceed with the rulemaking process of CCR Title 16, Sections 2030.3 and 2032.1.
As amended.
As amended.
I second that.
Second. Any further discussion? Any further discussion? Okay, call for the vote.
We have to do public comment again.
All right. Public comment from members in Sacramento. Okay, commentator, could you please see if there's any public comment from Hayward and from Webex?
Thank you, Mr. Chair. And do we have any public comment from Hayward?
No, we do not.
Okay, I have opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We'll give you a moment. All right, I see no requests for comment at this time. Shall I close the Q&A panel?
Yes, please.
Okay, it's closed.
Now a vote on this motion.
Dr. Sullivan?
Yes.
Ms. Shefelt?
Yes.
Dr. Bradbury?
Yes.
Ms. Laredo?
Yes.
Ms. Salazar-Sperber?
Yes.
Dr. Sequoia?
Yes,
Ms. Estrie?
Yes.
Motion carries.
Okay, now we need another motion for the VCPR FAQs.
I can make a motion to recommend that the board adds the drafted vaccination question and answer to the board's frequently asked questions. You have to read the writing.
I'll second that.
Any comments from the board, from the committee? I keep saying board. Okay, and there's no amendments to the, to what's in your page 3. Any public comments from here in Sacramento? Okay, moderator, can you please see if there are any public comments from Hayward or the Webex?
Thank you, Mr. Chair. Do we have any comment from Hayward?
no, we do not.
Thank you. And if any member of the public would like to comment through Webex, you may use the Q&A panel by typing comment in the field in the lower right-hand corner of your screen and submitting it to all panelists, or you may simply raise your hand. We're displaying instructions and we'll give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Yes, please.
It's closed.
Okay, then roll call for the vote.
Dr. Sullivan?
Yes.
Ms. Shefelt?
Yes.
Dr. Bradbury?
Yes.
Ms. Laredo?
Yes.
Ms. Salazar-Sperber?
Yes.
Dr. Sequoia?
Yes,
Ms. Estrie?
Yes.
Motion carries.
Thank you. Do we need a break or do we keep going? Okay, let's take a 10-minute break. Thank you.
Cameras are back live.
Okay, we are all set, and I see Dr. Sequoia is there, and so we are going to move on to agenda item 9, discussion and potential recommendations to the board regarding veterinary drug compounding guidance. So I'm going to have Ms. Usuri start. How is it pronounced? Usuri. Okay, got it.
Okay, so the board's drug compounding regulations became effective as of the 1st of this month. So our task was approached with a plan of developing an educational document that would serve as a guideline for practitioners on how to comply with these new regulations, and provide some background on them as well as to why we need to be doing this. While working with the board staff on the document drafts, it became apparent that there are a few holes in the regulation itself, and a few things that are missing that would allow for this to work really well. One of the things that's missing is a unique identification number or prescription number. It's not in the requirements, so in these compounded drugs, it affects the traceability of those drugs, that paper trail that's needed in the documentation. In addition to that, there is a portion of the requirement that it's intended that all drugs dispensed, all compounded drugs dispensed are logged in the medical record, but the word dispensed is left out of that. So as it sits right now, all compounded drugs used would be needed to be logged in the medical record. So that includes office use compounded drugs as well. As a subcommittee, we would like to develop proposed regulatory amendments to address the concerns that have been raised while looking at this. I don't know if Dr. Sullivan has anything to add as far as our process and what we found.
No, I think you covered it very well. You know, we're going to go through this section by section, and you'll see right away that in some ways it's kind of insulting to require somebody to write a formula for removing 1 milliliter of a sterile product from a multi-vial vial to another bottle to make a compounded preparation. And if you don't use it within 4 hours, you have to log it as a compounded product preparation. But that is what's required in order to continue doing compounding in a veterinary setting, which we all do almost probably every day. So I'm not sure. So what we attempted to do is to make this as easy as possible and to do it kind of like in spreadsheets. So the first error that we made was we didn't allocate a unique number or code to the formula of the compounding product. So we need to do that. And then we developed a spreadsheet showing how that compounded product went from making it to the client, and found out there's nothing in the regulation that requires us to document that. So that's the other big gap that's the other gap that we really have to address. I think maybe, unless you have questions in the memorandum as to why we are doing this, I thought maybe we would do some wordsmithing with the actual product that we're sending out that starts on page 4 with the introduction and why it's necessary to do this. So first of all, I'll ask if there's any questions leading up to page 4. I think it's pretty straightforward. Does the committee have any questions on it? And then I think we'll do public comment at the end. Is that all right? So, well, that's not going to work. Well, let's do this. So we'll start then with page 4, and we'll do it in sections, and then we'll ask for public comment because there's going to need to be some wordsmithing, I think. So on page 1, the first part of it is introductions, where we're explaining why we're needing to do this. Is the first paragraph clear? Is there any changes to the first paragraph that we need? And I think it's important, we've got a link in the title of the document, a link to the regulations, because it's critical that people read the regulations first, and then everything that follows here will make more sense. Dr. Bradbury.
It's not necessarily on this page, and maybe I should just let you keep going, but I guess my biggest concern with all of this and how to address or inform people is IV fluids and adding potassium or various items to IV fluids. Based on what I'm reading here is basically compounding medication, and it on I think the second paragraph on page 4, it talks about it has to have a supervised registered veterinary technician to compound drugs, a veterinarian or that, so we can't have assistants or anybody else in the hospital QSing fluids. And I guess my questions came later in the tabletop compounding regarding this, but it would apply here too.
Yes, if it's compounded, if it's a compounded preparation, the only two categories that can do that is a veterinarian or a RVT. That's just the way it is. If it's a well, even if it's an immediate tabletop preparation, technically, those are the only two people that can do it. Okay, Tara.
Since these are guidance on the new veterinary drug compounding regulations that were recently enacted, I'm wondering why, or rather, do you even need the first paragraph, which kind of discusses pending revisions to USP 795 and 797, which this board is not themselves changing. So it's kind of like an introduction about pending changes at presumably a federal level. So I'm wondering if it would be, since these are VMB's guidelines on its own regulations, I'm wondering if it would be better to strike the first paragraph and just go right into, in 2016, the California State Legislature passed this bill that promulgated a statute the regulations support.
That's up to the committee. I guess in starting this, I thought there needed to be some explanation of why we're here, because here we have people that have been compounding forever, and now all of a sudden they have to log down what they're doing. And I think it's not going to go down any easier, but I think if they know why, the U.S. Pharmacopoeia, when we addressed them, they would always say, we only do guidelines, we don't do enforcement. You have to talk to your enforcement people. And then when we see that the Board of Pharmacy in California decided to make U.S. Pharmacopoeia guidelines statute, that's where we're stuck because of the changes. So I thought it was a good idea to give some history as to why all of a sudden there's some pretty dramatic changes to everyday practice. If the committee thinks that it's not necessary, or is saying too much or doesn't get to the point. It doesn't need to be there. So I'll open that question up to the committee. The new guidelines, they're not by U.S. Pharmacopoeia. They're still reviewing the comments that were made in February. Latest that I have heard is that they will be coming out in probably in early July with a response, June or early July. So they are not approved yet, so it's not law in California yet, but I think we're looking at it being months.
So I'm wondering if it would be helpful to give a little bit more context to that discussion by potentially adding a sentence about the pharmacy law recently adopting USP standards, and to ensure that veterinarians were recognized as having separate needs with respect to drug compounding. In 2016, SB 1193 was enacted. So that way we're establishing that, you know, there's this USP going on at a higher level, that pharmacy law did something that frequently veterinarians have to comply with pharmacy law with respect to dangerous drugs and other controlled substances. There's crossover there. But when pharmacy law was amended to adopt USP standards, then veterinarians were provided for separately under the Veterinary Medicine Practice Act for their needs. So is it possible to just add a little bit of context in that first paragraph with probably just 2 sentences, which is, you know, add the date the pharmacy law was amended to adopt the USP standards. And since veterinarians have to comply with many statutes under the pharmacy law, veterinarians were separately provided for their needs under SB 1193.
Okay. So what you're saying is the requirement for what we're doing is necessary because we are part of the U.S. Pharmacopoeia guidelines?
Well, technically, what you're doing is solely because Senate Bill 1193.
Yeah.
It enacted a statute that allowed drug compounding completely outside of what's going on with the USP changes or pharmacy law. So the board had to promulgate regulations to flesh out what drug compounding is under 1193. That's what you're doing here. So effectively, the first paragraph doesn't really speak to that at all. But you wanted to provide some context.
Yeah.
So if, you know, context is great, and it also calls out, hey, there's this other stuff going on, folks. 795 and 797 are probably being amended. And that's important because pharmacy law adopted those as standards under pharmacy law, but veterinarians have different needs. So 1193 was enacted.
Okay.
Just kind of bridge the gap a little bit between USP and then immediately going into veterinarian drug compounding. It really is that middle piece of the pharmacy law adopting those standards that veterinarians needed to be carved out from, because there's a difference in veterinary drug compounding than pharmacy drug compounding.
Okay, if you can do that in 2 sentences, I'm happy.
So I'm going to work on that while you guys discuss.
Okay, good, good. Okay. Anything else that
Well, you know.
on the first part down to Roman numeral 2 from the board, from the committee? Okay. Are you fine, Dr. Sequoia? Okay. So let's open it up for public comment here in Sacramento.
Thank you, Mr. Chair. I have opened up the Q&A panel. If any member of the public logged into Webex would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I see that Anita Levy-Hudson has a comment. I know previously she was unable to unmute herself, but we'll give it a try again. Anita, you should be able to unmute yourself. There you go, you're unmuted. Anita, you're unmuted.
Okay, wonderful. Hello, as always, thank you for the opportunity for public comment. My name is Anita Levy-Hudson. I'm currently the president for the CARVTA. And I wanted to just chime in and just mention that it sounds like these are some pretty dramatic changes. And I just wanted to point out that, or ask, is there going to be, this information, is it going to be definitely shared and publicized so that other DVMs and practice owners are aware that this task is going to be restricted to DVMs and RVTs? Because I'm sure that that's something that is not widely practiced, if not widely not known. So I just kind of wanted to ask about that.
Okay, the material that we're going over now is going to be educational material that will go out to the licensees, the veterinarians and RVTs. The method or the way that it's going to be presented, whether it's email or a brochure or whatever, has not been decided. That staff will decide that, but we're putting this together so that we can get this information out to the licensees.
Yes, thank you. That's definitely what I wanted to know, because I thought it was going to be very surprising and limiting to a lot of practices.
Okay.
All right, and this is the moderator. I see no more requests for public comment. Would you like me to close the Q&A?
Please close.
Okay, it's closed.
Oh, is there any public comment from Hayward? Dr. Sequoia?
No, we have no public comment here. Thank you.
Thank you. Okay, then I'll open it up to the room here.
Thank you, Ken Pulowski. Following up a little bit on what Dr. Bradbury asked.
I'm not sure your microphone.
Yeah, is it on?
Okay.
It's on, yeah. Following up a little bit to Dr. Bradbury's comment about whether adding potassium chloride to an IV solution would have to be done by an RVT or veterinarian only. That concern aside, can you explain to me, so that then falls under the definition of compounding. What requirements, I mean, does that fall under, we have to have a defined plan stating all the ingredients that are used, the equipment that is used, that whole, how does that get done? Where does that go? I need to do that for every patient. We have multiple patients every day that get potassium chloride added to their IV solutions. And is that good for only 4 hours? Can somebody just explain to me in practice how this actually works?
The formula, it would be in the formula part of the document. But when a new preparation is made, unless it's used within 4 hours or begun to use in 4 hours, it would have to be documented on a spreadsheet.
Where does that spreadsheet? So we QS it to 20 milliequivalents or to 24 milliequivalents or to 30 milliequivalents. So we can have a standard document in our policies and procedures that describe how to make each of these and then reference that in the patient's medical record. Practically, I'm trying to understand how this, and I realize this is probably supposed to be happening already, I can guarantee you it's not happening in any practice out there.
Correct.
And to try and make this practical, and how does this work on a day-to-day practice?
Well, that's why you're here giving us some recommendations. The plan is either with hard copy or in a computer format template that the formula is in one section, and then you go to a spreadsheet that shows when it's being delivered. We do have a problem with the wording that we have in our regs right now, that we don't have it separated to office stock or to a patient. So if it's used in the clinic, we do have to make some new regulations addressing that as office stock. Everything we have in here is directed towards a patient. So I will be contacting you as to see what the best way of doing that in a clinic setting.
So are IV fluids, are those office stock, or is that patient specific?
Well, it would be office, well, that's what we have to decide. I would say it's office stock that then is administered to a patient, that there has to be some type of paper flow going to that patient. It would end up going into the hospital record with the treatment.
How has it been looked into? Does anybody know how this works on the human side? Because they add things to their IVs as well, and I mean, that may be something to look into. How is it handled? Are we being treated differently than on the human side? Because I understand the quagmire, and I appreciate you taking this up and trying to clean this up, but I mean, this becomes borderline untenable for multiple patients, and I mean, this has been done for, forever, and so thank you for taking this on, and I look forward to you contacting me, and I will provide whatever information we can to help.
So what we're trying to do is to have a enforceable paper trail as efficiently as we can do it. So in trying to do the educational material, we quickly discovered some gaps in the regulations that we're going to have to correct. And this is one of them.
Okay. Thank you.
Christy Pulowski. I want to speak to, you all know I support RVTs 100%. I am an RVT. We're in a time when we're in a shortage of veterinarians. We're in a shortage of RVTs. We have RVTs leaving this profession right now. We run a veterinary hospital, 24-hour veterinary hospital. To put this on RVTs and say that only RVTs and veterinarians can do this, we have at any given time, we have a 4 to 6 to 8 hour wait. In our area, we have a spreadsheet that shares this pandemic has given us a time that we have come together with ERs and we share our wait time and we share what's your wait time. We know what every ER in the area has as a wait time. There is not a day goes by that ERs are not closing down because they cannot accept any more patients. To say that RVTs and veterinarians are the only ones who can now put anything into an IV is going to delay even more treatment for more patients. Access to care is going to be limited because now you're saying veterinary assistants cannot assist these patients and only RVTs and DVMs can assist these patients. We have now gone against ourselves in what we're trying to do. We have limited access to care even more because less people will be able to help these pets. So these veterinary hospitals have just caused the workload. Their workload has now increased because of the paperwork that we have to do for something that we've been doing for years. So we're not thinking about the pets, we're not thinking about the consumers when we're trying to fill out more paperwork. And I get it, it's the law, but sometimes we have to look at, are we helping pets and are we helping consumers? We are not. Thank you.
I'm afraid that that requirement is in statute, which we've been looking at for years.
Yeah.
So,
It's 48, 26, 25.
Dr. Bradbury?
Yeah, I guess up until reading this document, did not think of IV fluids as a compounded medication. They were being, this is something we've done for years. Again, I like the idea of looking at how the human medical side of things manages this, because I don't think it's the intent of the regulations to be talking about IV fluids that are being given to patients in the hospital. I think it's the intent is when people are mixing things to send home with clients versus, treating in the hospital. So I could be wrong, but I don't know. I don't think it is possible for hospitals that are emergency specialty hospitals to follow some of these guidelines that are outlined here for things like IV fluids. If you have a patient that has diabetic ketoacidosis, for example, we are changing the potassium, we are changing the phosphorus, the potassium phosphate, we're changing the dextrose in the fluids, we're changing the insulin every 4 hours, and to have to get a separate number and we're documenting this in the record. This is a this has to be documented. It's the only way it's happening. But to have a separate form for each time this is changed, it's already very difficult to manage these patients with staffing and the doctors. I don't see how anybody would be able to follow these guidelines effectively and be able to care for patients and optimally care for them. I think people may end up doing things less optimally because they don't have time for the paperwork. So I guess I'm just confused. I didn't think of IV fluids as compounded medications, and it's just reading through this, I got the impression that they were, and I guess I'm surprised by that, and I'm not sure that that's true, and I guess I want some clarification as to how in human hospitals they're not calling this compounded medication.
So just a couple of clarifications. Again, these guidelines are not the ones who set any laws or changed anything. They're just saying what the current laws are. So you obviously have a concern with IV fluids, and I think you could do two things. You could either change it in statute to carve out some kind of exemption for administering or compounding IV fluids, or you can change the regulation. The regulation is obviously going to take a lot longer, but those are the two options that you guys would have.
Well, and to be clear, the statute specifically limits drug compounding to veterinarians and RVTs only.
Right.
So if you wanted to provide for veterinary assistance, that would have to be done in the statute.
But if we exempted IV fluid formulations and drugs administered in the hospital with IV fluids, that, right.
So you you are saying that every time you change what you're doing, it is in the medical record, correct?
Yeah, it has to be documented what you're doing.
Right. So
it's just a level of documentation that is being said here, and then it's, the other thing I guess I'm confused about is that you're saying that this document isn't changing anything. except we're proposing that we're changing something. So I guess I'm confused by that statement too, where you said, oh, this document's just advising on what's already in regulation, and then it says, however, each formula document is not required to have a unique identification number. The subcommittee thinks these numbers are necessary. So now you want to have a unique identification, you know, like, so that it seems like we are changing, we're asking to change something as well as informing people of that. So is that true?
That's true, that's correct.
Okay.
I would also say it says in there that if you are compounding a product, a preparation, and you have it in the medical records, you do not need to write it through this formula.
Great, that's perfect.
So
Fire is out there.
But it sounds like the more immediate problem is the fact that the assistants cannot compound the IV fluid.
That's true. That's another thing, yeah.
While the committee is suggesting regulatory proposals to include the other things that they feel is missing, that's going to take a long time. And it sounds like this is a more unintended consequence of the statute, and it might be faster to propose this change to the statute.
Can we do that? Can we make a recommendation to the board? Should I make a motion, or should we finish talking about it?
Well, I would say let's finish talking about it, and maybe we haven't written the regulations yet for office stock, so it sounds to me like that's where we need to look at other unintended consequences too.
And as far as timing goes, we kind of missed the boat for this session. So it would really be in the fall is when we would propose legislation. So I think we have time to craft something and bring it to the board.
Thank you.
And then the other question is, I'm sorry, go ahead.
This is pretty foundational, but talking about unique ID numbers, you're going to have to give guidance on how you want that number constructed. Are you going to just let every hospital start numbering from 1 and going up? Or are you going to make them put their initials in? I think the board needs to give guidance to practitioners about how to construct that unique ID number.
Well, the unique ID number is whatever a person wants to put down for that formula. So if you want to number them sequentially, if you want to have it related to a letter and number, whatever you want to do, so that unique number stays with that formula.
Well, that disturbs me because I think it's going to be very difficult if there are investigation or enforcement questions if hospital number A is using, code number whatever for lactated ringers with B vitamins added or something else, and hospital B is using something completely different. There's no consistency, and I think it's going to make a lot of extra work for auditing and investigating. I think it would be better to have some consistency at the beginning, like say, okay, for your categories, at least for all of your fluids, put them under F or something as your beginning of your unique identifier. I really don't think everybody should be able to do their own thing. Look at what's happened in the computer industry. There's very little standardization. If you want to switch from, PCs to Apples, it can be complicated. So I think this is something to be considered at this point in time.
All we are doing is tracking that product through that clinic. We don't care what Clinic B is doing. The investigator is going to want to know, with this compounded product that's going to a client, what is that formula, and to follow a paper trail from compounding it, the ingredients, their expiration dates, all of that information to that client. So when the next client comes in that's using that same formula, it's going to have that same code. So we don't care what another clinic is doing. We just want to have a paper trail within this hospital as to that particular product going through the clinic. What I think we our subcommittee needs to do in the interim here is relook at office stock real critically, and we need input on other areas that we need to address in following that paperwork. It says in there, and it's written, and it's in the human side, that if a formula is, and the information for that formula is put in the medical records, it does not need to be put in this procedures and policy manual. So we might be able to get around some of this with the in-hospital issues there, where like Dr. Bradbury said, where a patient, the fluids are being changed hourly. Well, if that's already noted in the medical record, this does not have to be documented separately. But we need to make sure that is clear. Okay?
Okay.
Okay, Tara, language time.
Okay, unfortunately, since we're doing a hybrid meeting, we can't display the text I'm about to read to you, but I'll go slow. So what I'm proposing is a new paragraph on page 4 of your meeting materials, which is going to be page 1 of the Veterinary Medical Board Guidance on Veterinary Drug Compounding. Under Section 1, Introduction, a new paragraph 2, which would read, and the purpose of this is to bridge the gap between the USP standards and the veterinarian drug compounding standards under the Veterinary Practice Act, and mention the pharmacy law, which, you know, also is applicable. So the new paragraph would read, in California, comma, the pharmacy law was recently amended to require compounding of drug preparations by a pharmacy to be consistent with standards established under the USP, period. Open paren, see Business and Professions Code, paren, BPC, end paren, comma, section 4126.8, period, end paren. Various provisions under the pharmacy law regarding prescriptions are applicable to veterinarians, comma. So it was important to establish separate drug compounding requirements specific to veterinarian practice under the Veterinary Medicine Practice Act. Then in the new third paragraph, it just goes on that you currently have, it's currently paragraph 2, it would become paragraph 3. In 2016, the California State Legislature passed SB 1193, which added strike Business and Professions Code and parens around BPC, because I've already defined it in the new paragraph 2. That's it. So this is just intended to provide that bridge to mention the pharmacy law, the new USP standards under pharmacy law for pharmacies, that veterinarians need separate practice guidance, and then we go on to Senate Bill 1193, which establishes veterinarian drug compounding.
Okay, comments by the board, by the committee? I do like it. It does give us a bridge there that is needed. Okay, let's do this piece by piece here. Let's see, any public comments from Hayward?
Nope, no public comment from Hayward.
Okay, moderator, can you open the open for public comments in Webex?
Thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I'm seeing no requests for comment at this time. Shall I close the Q&A panel?
Yes, please.
Okay, it's closed.
Any public comment from this room? Okay, seeing none, that will take care of the introduction with the additions that have been stated. What do you want to do on lunch? Because it's 12:11. This is going to take some time, I think. I think so. Yeah. Okay, let's go ahead and break for a half an hour for lunch. Actually, let's meet back at 12:45. Thank you. Okay, we'll call the meeting back to order. We're on page 4, number 2, Drug Compounding Policies and Procedures Manual. I hate the word manual because I think of a great big thick book, and what we're kind of envisioning is just a folder to have everything together, and in sections that make some sense and helps with the flow, whether it's a software program or whether it's a hard copy is not relevant. So are there any comments on the first paragraph of Roman numeral 2? Now we're following a format that is done both at Board of Pharmacy and Compounding Regulations and U.S. Pharmacopoeia. Again, our compounding is a lot more basic than what they're doing, but we're following their outline to make sure we've got everything covered. As I was mentioning to Jessica earlier, we did have some difficulty in getting the statute passed. As a matter of fact, we had the attorney for Board of Pharmacy at the time write it. They were not too happy with us doing this, and we explained why we needed to do it, have the ability to do it, and so the initial statute was okayed by them after quite a few meetings, and the importance of the need for it. So that's one of the reasons we're kind of following their outline. So for the board members, are there any comments on that paragraph for item 2? Is there any comments from the public in Hayward?
No
public
comment from Hayward.
Okay, moderator, can we ask the public for public comment on Webex?
Thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We will give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Yes, please.
It's closed.
Any public comments from the room here in Sacramento? Okay, then we'll move on to Roman numeral 3. And I think so this is, and we do have an example of a couple of formulas. And the only thing we're lacking in this part of the document is the need for each formula having a unique identification number. So I need all of you thinking of the unintended consequences of what we're doing so we can get it straightened out. Okay, I'm going to go on to the next, there's no board comments. I'm going to go to the next section before we open it up to public comment. Quality assurance program. We just need an area in the manual that lists any adverse reactions to a compounded product. And in the regulation, it states the time that you need to notify the client, but also it has to be documented. Any board comments? So we'll quickly go to Roman numeral 5, which is labeling of the compounded preparation. In this section, it refers to section 2030.2, and that is to include, now this is for dispensed medications, we're going to have to make that clear. That's because our labeling equipment and our software, or equipment and software, is pretty restricted on what information can be put on there. So 2032.2 is what we commonly use. Any committee members' comments? Okay, so before we go to definitions, I want to open it for public comment. Is there any public comments from Hayward?
No, no public comments, Hayward.
Okay, moderator, do you want it to open up for public comments on Webex?
Thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We'll give you a moment. All right, I see no request for comment. Shall I close the Q&A panel?
Yes, please.
It's closed.
Any public comments from members of this room? All right. So now we're going to get to definitions. There are a couple of items, or a couple of words and comments that we felt needed to be defined. They are listed in the regs, but we wanted to make sure they were as clear as we can make them. So starting in definitions, under A, well, let's just start with A1. Does the committee have any comments on, we'll do A1 and 2. Page 6, item 3, definition 3. Yes, Dr. Bradbury.
All right, this is where I started realizing what we'd done. So make a compound for A. Tabletop compounding is when 2 or more sterile products are combined to make a compounded preparation and are used within 4 hours. So, for example, a bag of IV fluids, if it was combined, made into a preparation, and then began administration within 4 hours, but is still administered over a 24-hour period, does that then after 4 hours?
That's a good pickup because it should state is started within 4 hours.
Okay, great, thank you.
Dr. Sullivan, I'm sorry, I would like to ask a hair-splitting question going back to number A. Compounding is any of the following. If I choose to give the Valium to the seizuring dog, not orally, but rectally, is that compounding because I'm changing the delivery system?
I do not think that is changing. That's not compounding.
Okay, thank you.
Any more comments on tabletop compounding?
I do. So can you let us describe how you, the subcommittee, came up with tabletop compounding? Where did that come from?
Pharmacy law.
Okay. But that's not specifically in the regulations that the board enacted.
Correct. If we need to somehow put it in, we'll need to do it, but it is part of the Board of Pharmacy law.
Okay.
Regulations. Okay, and the definition of office stock, any comments?
I guess I just had one other question. If it's not this tabletop compounding, then it's just compounding? I mean, what is it if it's not tabletop? So it says like if you use it again later in the day or use it the next day, then it is no longer a tabletop preparation.
So it somehow has to be documented either within this manual, we'll call it, or in the medical records.
Okay, so then it is not, it's just a regular compounded medication if it's not tabletop. Okay.
Yeah. Okay, and then number 5 then defines that if you're not doing something regularly or it's unique, very unique to the patient, and it's in the information is in the medical records, it doesn't have to be in the policy and procedures manual. Okay, and I think that may allow us to change dosages as the patient is hospitalized, but we'll work with you on making sure and others to make sure that we make it as straightforward as we can, as usable. Okay, so let's open up the definitions then to public comment. Is there any public comment from Hayward?
No public comment from Hayward.
Okay, moderator, can you open up for the Webex for public comment, please?
Thank you, Mr. Chair. I have opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I see no requests for comment at this time. Shall I close the Q&A panel?
Thank you. Any public comment from this room? I don't believe this. Okay. Seeing none, we'll keep moving on. And then item B is the definition for expiration dates for non-sterile and sterile compounding. Any comments from the committee?
Comment.
Okay. Yes.
Expiration dates, looking at B for sterile compounding. In your last sentence, the shortest expiration date or beyond user date, I think it should be of, not or. So you want OF, not OR, any ingredient in the sterile compounded preparation?
So in compounding products, preparations, they always use beyond use date. But
No,
many
I'm
of our,
not saying, I'm saying that go beyond that to or any ingredient.
oh, I'm sorry.
I'm saying it should be of any ingredient, I think.
Okay. Thank you.
Sure.
Okay, I think we're ready for public comments. Any public comments from Hayward?
No public comment.
Okay, moderator, can you check to see if there's any public comments on Webex?
Sure. Thank you. So I've opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists. Or you may simply raise your hand. We'll give you a moment. All right, I see no requests for comment at this time. Shall I close the Q&A panel?
Thank you.
You're welcome.
Is there any public comments from this room? Okay, seeing none. And now our decision is, what do we do now? So, well, first of all, I forgot. If you go to page 7, that's an example of a formula page that needs to be filled out for the only thing that's lacking in there that we need to amend through regs is a unique number for the compounding drug preparation. And then on pages 8 and 9 are simple examples of doing a formula. I asked one of our associates to give me an example of some compounding products that she prescribes. I said, just give me a few in 15 minutes. She gave me 9. So it is something that is done every day in practice that we now have to develop and follow procedures on. Okay, so this, any comments from the committee on this template? So this template and others to follow will be just examples how to satisfy these regulations. Okay, any public comment from Hayward?
No public comment.
Okay, and a moderator, could you ask if there's any public comment from Webex?
Thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen, or you may simply raise your hand. I see Anita. Yes, Anita Levy-Hudson has requested to make a comment. Anita, you should be able to unmute yourself. If not, I'll read your comment.
Okay, looks like I was able to. I have a question about oversight for this. This seems like such a daunting process, and definitely application is going to be a little bit tricky initially. who is the organization that oversees this, or who will be asking to see this documentation in our hospitals?
That would be done by the Veterinary Medical Board on any disciplinary inspection or any routine inspection.
Okay. Okay, thank you.
All right, I don't see any further requests for comment. Shall I close the Q&A panel?
Yes, please.
Okay.
Any comment from this room? Public comment? Okay. Now we have a couple of decisions to make. Yes. Dr. Bradbury.
Sorry, I just wanted to say thank you. This obviously was a lot of work, and I know it's been a little contentious. And before we moved on to the other part, I just wanted to thank both of you for all the work you did on this and putting together those forms and stuff. This is clearly a lot of information, and I just wanted to say thank you.
Oh, thank you. It was a group effort. Marie did a fabulous job, and staff. We had a couple of meetings, and it is, you know, it until you get down and actually work out a actual situation, you don't see the gaps that are there. So. And I think it's when we have something this significant, I think we do need to get education material out to the licensees. We shouldn't be just leaving it up to them. And obviously, from discussion today, we need to address some specific issues. So the first question that we have today is whether we move this forward to the board for approval or comment or discussion and back to us, or however we want to do what we've done today. As it's written, it reflects what the statute and the regulations say as of today, and it is, you know, it's out there. So we can only, as an enforcing agency, we can only enforce what we have written. So the question is, do we put this forward to the board to get information out to the licensees, or do we wait till we have a more finished product? And since this is already law, I think we need to get at least some information out to them. So, but this committee needs to make a decision as to what we are doing today. So I think what I'll do is just ask our committee members what comfort level they are with moving at least this information forward. Marie, I'll start over here.
I mean, I think it's a great start in giving them direction on something that, like you said, is already law. So I'm comfortable moving forward what we have with the added couple of sentences that we did today.
Okay. Leah?
Yeah, I would agree that we have to put something out there if these laws are already in effect and people are asking these questions. Just like with our other FAQs, putting them out there that this is where we are today seems reasonable.
Okay. Dr. Bradbury?
I guess I'm a little concerned about this really changing, or I'm searching for the right words. Obviously, this is going to be really challenging for people to digest and change their policies as we're still looking at. I know it's law right now. I guess I'm concerned with putting this out at the moment. mainly just, I don't know what people are going to be doing, you know, with this information. I know what they're going to be doing with this information. There's going to be a lot of kind of panic over it, I think, in the veterinary community. And I think it, you know, like how Christy was saying, you know, sometimes an overnight staff, like, are they now not going to be able to give fluids that, you know, and I know technically now they're not able to give, to adjust fluids, you know, without the veterinarian doing everything. So I like that we're advising people. I think this is going to, if we're planning on adjusting it and changing it and having that be a near future change, I might vote to wait, but
Okay. Jennifer?
So I'm on the fence with this one. I agree we need to have something on the website, the FAQs. There's a lot of confusion, and something is better than nothing, but this is a work in progress. So we've seen some of our regulations take years, and we spend a day talking about changing one word, but I do agree that we need to get something out there. So I understand Dr. Bradbury's point of not wanting to create a panic, but maybe creating a panic will get more involvement from the industry so that we can start talking about this and trying to fix the issues. So I'm undecided.
Okay. We don't have a motion, so let's open it as we did before. Let's open it up for Dr. Sequoia. Did you have a comment? Oh, yes. I think you're muted.
I think it would be good to say this is a work in progress. There will be changes coming. We will keep you apprised, but this is just to get you started figuring out ways to be in compliance with the existing law. And then they can go back and read the bridge statement that as of April 1st, this became law, and it wasn't something anyone chose. It was sort of imposed on the veterinary field. But we have to live with it. So I'm in favor of putting it out there with the disclaimer at the bottom.
Okay, let's get some public feedback before we make a motion. Any comments from the public at Hayward?
Nope.
Okay, moderator, can you open up Webex for public comment, please?
Sure. This is moderator. The Q&A panel is available. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We're displaying instructions and we'll give you a moment. All right, I see no requests for comment at this time. Shall I close the Q&A panel?
Yes, please.
Okay.
Okay, public comment from this room. Oh, come on. We need some direction here, folks. Okay. This committee needs to make a decision as to what we go forward with. I think the options are to hold back until the next meeting and see what the board wants us to do in addition to what we've already defined as gaps. The second option would be to move what we have forward, knowing that we're probably, knowing that this isn't a complete job. I guess those are the two options. Or the third would be to just do an information notice like the introduction on the website until we get further development on this. The problem is the development we need is going to take some time, but that's where we're at. Dr. Bradbury.
I mean, I think that this is a pretty informative document, and it does outline some good guidelines for people. And I think if we just put the informational part of it, we'll just get a ton of questions anyway. And so even though I kind of on the fence about, I know how this is going to go over, I think that the information is helpful for veterinarians. So I think maybe it is better to just move forward with it for now.
Okay,
yeah. So I'll make a motion to recommend. I'm sure there's wording in here somewhere.
Page 3 at the end.
Yeah, okay, there it is. I recommend the board approves the material for posting on its website and dissemination to all licensees and stakeholders.
This is Dr. Bradbury. Is there a second?
I second. Sequoia seconds.
Okay, Dr. Sequoia is the second. Any further comments from the board? Yes, Sarah?
Just to be clear on the motion.
As amended.
Right now, it's motion to recommend the board approves the material. So perhaps we could just say motion to recommend the board approves the guidance on drug compounding material.
As amended.
As amended.
So I'd like to amend my motion to have the MDC recommend that the board approves the guidance on veterinary drug compounding document and courtesy formula form for posting on its website and dissemination to all licensees and stakeholders. As amended today.
Dr. Sequoia, is that second okay?
Yes.
All right. Jennifer?
And just to follow up on Dr. Sequoia's suggestion to Tara and Jessica, is it possible to have a disclaimer at the top of this document once we put it out there for public information?
I think it was our doing, though. Yeah, it was our regulation, so it wasn't forced upon us. It was...
The board approved and adopted regulations as required under the statute. So these regulations support and clarify the Veterinary Medicine Practice Act. So I don't know that there's any disclaimer to provide.
I know we have to do public comment again, right? Yeah. Okay. Any more comments from the board, from the committee? Any comments from the public at Hayward?
No comments.
Okay, moderator, can you ask for public comments on Webex, please?
Thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I see no requests for comment at this time. Shall I close the Q&A panel?
Yes, please.
Okay.
Any public comments from this room? Okay, call the roll for the vote.
Dr. Sullivan?
Yes.
Ms. Felt?
Yes.
Dr. Bradbury?
Yes.
Ms. Laredo?
Yes.
Ms. Salazar-Sperber is now absent. Dr. Sequoia?
Yes.
Ms. Ustry?
Yes.
Motion carries.
Thank you. Okay, action item number 10 is Complaint Process Audit Subcommittee. Dr. Bradbury and Dr. Sequoia.
Dr. Sequoia, are you okay with if I go over this?
Oh, I would appreciate it because you have much more background in it than I do. Thank you.
Oh, okay, thank you. Okay, so the focus of our attention for the last few months has really been on the expert witness training session that occurred on March 28th, which was a huge success. We had realized that we needed to do a more focused training session with our experts rather than just sending them to the medical the medical board's expert witness training. So our DAG liaison did a great job of putting together, Ms. Never, of putting together a PowerPoint presentation, and we did it through Webex, and we went through and had question and answers along the way. There was quite good participation in attendance, and our experts were very engaged, which was encouraging, and asked a lot of questions. And the training went on for a little bit longer than we even expected, which I thought was a good sign. We did touch on, all aspects of what we expect them to do and don't expect them to do. The biggest things that we covered were establishing the standard of care and having them really focus on that versus some other things that I think they may have thought they needed to opine on. How to describe deviation from standard of care. We talked, and then we had a conversation about the resource materials at the last meeting. The last MDC meeting, we had gone over that a little bit, and it was a little more contentious than I expected, that topic. And just to clarify, the idea behind the reference material was not necessarily that they're supposed to be reading through that before opining on a case, but more when they've made a comment about the standard of care, the way they see it, being able to just insert a reference to show where they get that information from. It helps the staff and the case in a lot of ways. But we talked about appropriate sources for that, being more general knowledge information like veterinary textbooks, and I know that we talked about VIN, but we want to make sure that they have good resources if they are going to be using them. So we had some discussion on that. After the meeting, we got a lot of feedback, and it sounded like, again, they really appreciated the training. And, another thing I just want to touch on here is that when we were discussing when they get a case, we made it very clear that they are allowed to say, hey, this is beyond the scope of my knowledge, and that was we clarified that with some of the experts. If they were receiving a case that they really didn't have a lot of experience on, we've always asked them to let us know and send it back if that's the case, but we just wanted to make sure that was clear to them, and it did seem like they got that they understood that. But anyway, after the training, with the feedback that we got and looking over some of the questions, I think we've decided to have more regular roundtable discussions. It wouldn't have the board member, like I wouldn't be participating in that, because we want them to be able to talk to the enforcement staff more and ask questions. Even if they had specific case questions, we can't be there for that. So, but we are going to have more regular roundtable discussions so that they have the opportunity to ask questions and have, I just think, have more feedback and direction. I think it's going to help a lot, and like I said, they all responded really positively to this, and from some of the questions, it became pretty clear to me that this is a helpful, just a helpful thing that we're providing for them, and I think it's going to help improve the program even more. So that was, I thought, a big success. And then also the regular, some more feedback on the reports. They asked for more feedback, so we'll definitely be providing that as these cases start to roll through that are reflecting the process changes that we've already put into place. So just to touch on some of the things that we talked about at the last meeting, the complaint review, as just mentioned, that is still on pause, but I would assume that soon. Rob, when do you think that'll come back online? I don't know where we're at with the...
Yeah, I don't have an exact date. I would assume pretty soon, because we obviously have additional staff, so we're going through the cases a lot more quickly. So,
okay.
But as far as some of the cases that we've had to work that are a little bit newer, maybe because they've been combined with an older case, that have been reviewed based on the new guidelines and training, I have been able to give feedback to our experts on some of those cases, just based on what they've provided already.
So maybe we'll be starting to review some of those cases on the subcommittee as well.
Right.
Great. Yeah. So we'll as soon as that seems to be catching up with the process changes, we'll Dr. Sequoia and I will be starting to look at those. I would think maybe by the end of the year. It would be my hope, or something like that. Does that sound? And then the real-life examples for expert training, we've been talking about this for a while, and I apologize, that hasn't gotten completed yet. That is one of the top things on our agenda, so Dr. Sequoia and I will be looking at that and have at least one case for example for our experts by the July meeting. The references, I touched on that. We're just going to give them a list of some of the materials that are provided for the vet schools. We've gotten those from our student liaisons, and it's an exhaustive list. And again, it's not for them to necessarily be looking into those. And this was made pretty clear in the training. It's not that they're supposed to be reading through those and then forming their opinion. It's more just so that they have some idea of what where to look for some of these resources if they're just trying to cite, like, you know, the Baytril dose is 5 mg per kg in a cat or something. In any case, the last thing that is also top of our agenda in the subcommittee is reviewing the subject matter expert criteria, and we should have our recommendations by the July meeting. And that's it.
Okay. Thank you. Dr. Sequoia, do you have anything to add?
No, I would just say that Dr. Bradbury covered it very comprehensively and concisely, and thank you.
Okay. I do have public comment. Okay, any public comment from Hayward?
From Hayward, no.
Okay. Moderator, can you check to see if there's any public comment from Webex.
Thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I see no requests for comment at this time. Shall I close the Q&A panel?
Thank you.
You're welcome.
Okay, and public comment from this room, Dr. Miller.
Hi, Grant Miller, CVMA. Why is this table so close? Jeez, scary. A couple of, if I can, questions. Under the real-life examples for expert training, it says our new member is up to speed. Who is that in reference to?
Dr. Sequoia, she
Okay.
just joined us. Yeah.
Thank you. That's what I thought. I just want to be sure. And then one request would be that regarding the, for lack of a better term, the library of expert references, and then the subject matter expert criteria, if that could be available for public view, that would be very helpful. Thank you.
I think that should be doable. Makes sense to me.
Okay, any other public comments in the room? Okay, and that gets us to the important action item number 11. Jessica.
All right. So our future MDC meeting dates are July 19th and October 18th. We do anticipate them being here again in the hearing room and also providing the hybrid option. We have a list of current MDC assignments, estimated meeting schedules, and current subcommittee members that are assigned. Again, this is a new thing that we added to make sure that everybody was aware of what's on the MDC plate and when we anticipate tackling each item. So with that, I'll entertain any questions or suggestions. All right.
Okay. Any public comments from Hayward?
No public comment.
Okay, moderator, can you open the WebEx for any public comment?
Thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the right-hand corner of your screen, or you may simply raise your hand. We'll give you a moment. All right, I see no requests for comment at this time. Shall I close the Q&A panel?
Yes, please.
Okay, it's closed.
Any public comment from members in this room? Okay, seeing none, I'm to the end of the agenda. Yes. Do we need a motion? Nope. Okay, this meeting is adjourned.